Hi, thanks for joining me for a brief overview of the C. diff colonization point prevalence pilot study that will be starting on September 1st on Lunder 9 and 10. My name is Erica Shenoy. I'm an infectious disease doc here at Mass General, and I do infection control, and I'm the PI for the study. So I'll just go briefly over the study. I'll give some introductions, talk about the study aims, the workflow, storage of all the materials for the study, and some questions. So that's me. I'm the principal investigator, as I mentioned. Dr. DePhilippe, who I think many of you are familiar with, is a co-investigator. Also working on the study, we have Noah Fetter, who's our clinical research coordinator, and Lauren West is our data analyst. So a little background on C. diff. Much of this you probably know because you deal with C. diff clinically on your unit. But C. diff causes about 500,000 infections a year in the United States. About 2/3 of these are thought to be healthcare associated, and there's unfortunately an associated 30,000 deaths. Patients who are asymptomatically colonized for C. diff, that means that they carry the organism but experience and exhibit no symptoms of disease, may be at high risk of going on to develop disease, i.e. develop symptoms and have C. diff infection. And they may also contribute to transmission. If we don't know that they're colonized, they could be depositing spores in the environment. Those spores live for 5 or more months in the environment and then can be potentially transmitted to individuals who go on to become colonized and then develop disease. So why screen for colonization? A recent study found that if you screened and then isolated the 5% of admissions that were identified as colonized, they were able to show a decrease in C. diff infection over time. And they estimated that the intervention had prevented about 63% of the expected cases. However, this was a pretty small study, and currently screening for and isolating individuals who are colonized with C. diff is not MGH policy, and it's not one of the main recommendations from the Centers for Disease Control and Prevention. Why the focus on oncology patients? So as you probably know, oncology patients are at risk for C. diff infection and, if infected, for poor outcomes. The risk of C. diff in oncology patients is reported to be 26 times greater than for all other hospitalized patients. And oncology patients who go on to develop C. diff infection have significantly higher mortality and length of stay than non-C. diff infected oncology patients. Thus, screening and isolating oncology patients who have C. diff colonization may have benefits in terms of isolation of those individuals to reduce the risk of onward transmission to other patients. And also, if we identify those who are colonized, they would be at higher risk of progression to C. diff. And factors such as antibiotic exposure could be modifiable and thus reduce their risk of going from the colonized state to the infected state. These potential benefits must be weighed with the cost of screening and the impact of patient isolation. So this brings us to the study aims. Aim 1, which is the one where we focus most of all and most of your work on, relates to conducting this point prevalence study of patients who are admitted or transferred to Lunder 9 and 10. These patients will be screened by you, the unit-based nursing staff, using a rectal swab on admission and transfer around the same time, either before or after you do the VRE rectal swab, which is part of the normal admission process. We're going to be processing those using a PCR test to determine the colonization status. Those data will be collected. They will not be in the electronic health record or available to the patient or the clinicians on the team, but they will be available to the researchers on the team. And what we will do in Aim 2 is to use those data to quantify the proportion of our C. diff cases occurring in patients who are actually colonized on admission and who go on later to develop C. diff. And this will help us reclassify what previously might be considered nosocomial versus community acquisition, and to think about how that impacts the infection, standardized infection ratio for nosocomial cases. And then we will be using these data in a separate activity in Aim 3 to develop a machine learning way of trying to predict who will be colonized on admission. And we've done this successfully already here at MGH and at the University of Michigan in order to identify patients who are at high risk for C. diff infection. So we'll be learning something different in this aim, which is who's at high risk for C. diff colonization. So into the Lunder 9 and 10 nursing workflow, the first step is to obtain verbal consent and provide the patient with a standard information sheet for the study. Then you will be documenting that verbal consent in a research note. So that's the type of note in EPIC. And then you use the dot phrase or the smart phrase .cdiff study and then fill out very few bits of information there, and it should be quite straightforward. The sample will be collected. You'll fill out a paper requisition form with just a few items there, as we pre-filled out most of it. Put an ADT label on the requisition itself and the sample and put it in the microbin. In terms of obtaining verbal consent, we ask that you approach the patient at the same time as you're doing their admission VRE rectal swab, and ideally this is collected within 24 hours of admission or transfer. You can explain the study obviously to the patient, and there is a very brief nursing dialogue that can give you general guidance. We don't ask that you read this like a script, but it does provide you with some of the background to generally anticipate the questions that the patient might have. Now, the patient information sheet that you give to the patient will actually have most of the questions that we anticipate a patient will ask, and there's also contact information for them to reach either myself or Dr. DeFilippe if there's more questions that they have. And then you obviously ask for consent. For non-English speaking patients, you can use the interpreter over the phone, and that's approved for this study. Now, some patients might refuse the rectal swab, but they really do still want to participate in the study. And for those patients, you can offer, while not the preferred method, so we still want to emphasize that the rectal swab is the preferred method, that if they are willing to be part of the study but not willing to do the rectal swab, if they're able to produce a stool sample, then you can take the swab and sample the stool sample and then submit the swab to the microlab. Documenting informed consent, as I mentioned, is quite easy in EPIC, so it should be documented, and this is important for every discussion that you have. If the patient says yes or no, for the purposes of this study, we do need to know that they were approached and what the outcome of that was, yes or no. If you create a research note in EPIC and you use the phrase .cdiff study, all of this content will appear, and then there's just 5 items that are pretty easy to do in that we've already pre-populated, and they're usually radio buttons or drop-down menus where you can select, are you on Lunder 9 or 10? What was the consent status, yes or no? Their discussion date and time, so the date and time when you had that discussion, whether you did a rectal swab, whether you did the stool swab, or if they did not consent, then you would put NA, and then whether or not a interpreter was used, yes or no, and then sign the note. For collecting the sample, it's pretty straightforward. As I mentioned, the rectal is the preferred method. You collect the rectal sample using the designated study swab, and this is different than the VRE swab. It's a red cap, and it's got 2 Q-tip-like devices on the end, and both of these go in as part of the rectal swab. You can either do it right before you do the VRE swab or after you do the VRE swab. It doesn't really matter, but what matters is that you use the right swab and that you do get a rectal sample. This is not a perirectal sample, it's a rectal sample, and you want to get stool on it. Again, if the patient does not consent to the rectal swab but still wants to be part of the study, when you collect a stool sample, you can then put the swab, the same swab that's there, the red cap swab, and here we just have a little picture of what's too little, what's too much, and what's the correct amount. The requisition is pretty much pre-filled out, so there's only actually 2 things that you need to fill out and 1 label to be placed. So like with most things, you record the date and time that you collected the sample. It'll already have my name on it, and it will have my provider number. And then depending on whether you did a rectal swab or a stool swab, you just check that off. The test is already checked off, and put a ADT label on it, and you're done. You do not need to place any orders in EPIC. There is no order for this. And please only use the study requisition, because that's how the microlab knows that this is part of a study. Then you just put the ADT label on the swab, and you've already done it on the requisition, and you put in the clinical microbin, and it's ready to go for transport in the normal transport process that you use for other specimens on your unit. Where to find study materials. So all the materials that you need for the study will be in the infusion room. So that's where the study swabs, the requisition, the patient information sheets, and the nursing dialogue will all be there. And your unit coordinators will contact Noah, the clinical research coordinator for our project, when supplies need to be replenished. Now, there are other locations, say in the middle of the night, and you just don't have a piece of the patient fact sheet, or you just need to look up more information about the study. We've posted these all on Apollo. So this is on the left of the screen. This is the homepage for infection control, and you can see all the very familiar tiles that you may have seen related to COVID-19. But here we have this tile related to infection control research studies. And if you click on that, you'll get to a tab that has all this study listed. It's got the name of the study, the protocol number, and then you have these neat links to the patient fact sheet, the nursing dialogue, the workflow. And once I finish recording this, we'll post this little tutorial for you. There's also a handy FAQ for clinicians. So if you find that responding clinicians or others or amongst you have questions about the study, these are the basics here. They cover things like, will I get to see the results? And the answer is no. And will the patient see the results? No. And what if I suspect C. diff? Should I send a test? And yes, none of what's going on in this study should impact the regular clinical course of care. So we just want to make sure that you're aware of all those resources that are available to you. Well, obviously I can't ask you questions while we're doing this asynchronously, but in our 2 sessions that we've had with your teams and working with your nursing leadership, we have tried to include as many of the questions that we've heard into the study materials so that they're answered. But of course, things may come up, and we definitely want to hear from you. So if there are questions, if there are common things that the patients are asking you or that come up, please do reach out to Noah, and then we can update our materials and answer your questions accordingly. I just want to say thank you. This has been a study that we wanted to do for a few years. We got sidetracked, obviously, by the pandemic over the last year and a half, and it's just such a really exciting time for us as a research team to be able to begin to ask these questions and to partner with you on the project. So thank you so much, and we'll see you soon. Bye-bye.